Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of Thyroid Thursday, and today we're talking about bone density. I was asked if I would explain how thyroid hormone and thyroid conditions affect bone density. So we'll get into it. Thyroid hormone in general, in what we call homeostatic low stress state, where your thyroid gland makes enough thyroid hormone, there's not a lot of inflammatory processes going on in the body, we feel and function pretty good. Thyroid hormone balances the breakdown, what we call bone resorption and bone formation, so that we have stable, solid bone density. Now, what is the biggest driver of osteopenia, which is mild bone loss, and osteoporosis, which is more aggressive bone loss? At the end of the day, the most common driver of that is typically inflammatory mechanisms for various reasons, but that's the big driver, okay? Physical activity, exercise, good diet, good nutrition, all of those really important to maintain bone density. But if you have too much inflammation going on in the body, that results in an upregulation of something called NF-kappa B, and NF-kappa B then increases osteoclast activity, which means you're going to have more bone resorption. So you're going to start to lose bone density and bone mass. A lot of people think it's just a vitamin D issue or a calcium issue. That's too simplified. The biggest driver of bone loss is inflammation. So reducing the inflammatory process is really important. But if we have somebody who has true hyperthyroidism, they have an autoimmune thyroid disease that's causing hyperthyroidism to occur, too much thyroid hormone shifts the balance between bone resorption and bone formation towards bone resorption, and this leads to bone loss. So anybody who has hyperthyroidism, they're at a greater risk for bone loss, which is one of the reasons that we're concerned about our hyperthyroid patients. It can start off early on as osteopenia, which is the less bone loss, and then it becomes more significant. We call that osteoporosis. If you have too little thyroid hormone, this also can create changes in bone function. In hypothyroidism, we have reduced bone resorption and we have decreased bone formation. So we have decreased bone remodeling. We lose this balance. We have older bone. It can have more mineral density, and it can still put us at risk for fracture. Okay, but what happens to the hypothyroid patient is if they have this going on for a while and then they're provided thyroid hormone replacement, that thyroid hormone replacement is associated with, unfortunately, some bone loss as we start to give that person thyroid hormone replacement. So does that mean you shouldn't take thyroid hormone replacement if you're truly hypothyroid or primary hypothyroid? No, you should take some, but we don't want to over-medicate somebody, driving their TSH too low, especially the elderly. It's shown in the literature that as we get older, TSH should naturally start to increase. It's not broken physiology based on the literature, but adaptive physiology. There's a reason the body is causing TSH to go up, and if we rush in and suppress that, even though somebody might have some hypothyroid signs and symptoms, we could actually be doing them more harm than good. Now, we're not talking about situations where TSH is, over 10. We're talking about those cases where somebody's under 10, maybe is diagnosed with subclinical hypothyroidism, meaning their TSH is elevated, but their T4 or free T4 is normal. Sometimes those patients have hypothyroid signs and symptoms, and we rush in with thyroid hormone to try and help them, even though the literature says, hey, don't treat them. And we think we've done a better job for this patient because temporarily they might feel better. We've suppressed their TSH down to within a lab reference range or even below the lab reference range, and we think we did a great job for the patient, but we may have actually put them at greater risk. Not a good thing. TSH has a benefit. So a lot of people think if they just suppress TSH, that doesn't have any effect because TSH only affects the thyroid gland to produce thyroid hormone. But that's not true. TSH has receptors in lots of different tissues and especially at bone. So as we age and TSH is going up naturally, this may be driving the thyroid gland to make more T4 into T3 at the thyroid gland and help support maybe reduced peripheral conversion. But TSH also has a protective effect on the bone. So, couple key points from this kind of Thyroid Thursday here. What's really driving the inflammatory process is we've got some type of excessive cell stress, we've got chronic low-grade inflammation going on, and these things start to drive immune dysregulation. And when we have immune dysregulation, that can result in these autoimmune thyroid diseases. So we need to address this. Oftentimes when we have an autoimmune thyroid condition, instead of addressing the cell danger response, the inflammatory cascade, we just say, hey, the immune system has become dysregulated. We're gonna either knock out the thyroid gland and assume that fixes this stuff, and it doesn't in most cases. Or we say, well, we'll just wait for the thyroid gland or the immune system to create enough damage to the gland that they can't make enough anymore, and we'll just give them thyroid hormone. We'll just treat the lab, or we'll treat the levels in the blood. But that doesn't change the fact that the person has a cell danger response, they have an inflammatory cascade, they have an immune issue going on. Doesn't change that. So if that process is still going on, they're no longer in homeostasis, they no longer have a great balance at the bone between bone resorption and bone formation, and now we come in with just thyroid hormone to try and balance the levels. The addition of thyroid hormone in a continual inflammatory state is we're going to add more thyroid hormone. What's that going to do? That's going to cause bony demineralization. We're going to suppress TSH, which takes away the protective effect of TSH. And what is the protective effect of TSH? The rise in TSH is thought to protect bone density. So suppressing TSH in an effort to treat the labs or decrease symptoms actually can put the patient at greater risk for a lot of issues, but especially for bone density loss. I know you might be thinking, but I have hypothyroid signs and symptoms. I get it, but if you don't meet that classification where you have insufficient T4 to support the physiology, and somebody diagnosed you with euthyroidism but treats you anyway, or you're diagnosed with subclinical hypothyroidism and somebody treats you anyway, we may be putting you at greater risk, and we may definitely be putting you at greater risk if we still have chronic inflammation, cell danger response, and immune dysregulation, okay? Here's a key point. I've talked about this before. 60 to 90% of the people on thyroid hormone replacement therapy are thought to be treated inappropriately because we're treating them when their TSH is out of the lab range, but not in necessarily an appropriate range to treat them. Meaning they either have subclinical hypothyroidism, TSH is above the lab range, but T4, free T4 is normal, or they have a normal TSH and a normal T4, and we're treating them just because they have symptoms. People want to either manage the labs or help the patient, but that's probably not the best option. Yes, it might make you feel a little bit better temporarily, but there's long-term ramifications to somebody by treating them when you shouldn't treat them. But that doesn't mean we shouldn't help them, okay? We need to look at what's going on in their physiology. Do they have this chronic cell stress inflammatory process going on? Do they have immune dysregulation? And that's what we need to put our time and attention to. If we treat them too early in an effort to try and placate their symptoms, we actually may make this whole scenario worse and push them further down the path of immune dysregulation, osteopenia, osteoporosis, and bone mineral density, and increased risk of fracture, then plus a whole bunch of other issues. So what do we need to do? I think we need to do more thorough evaluations, not just a TSH and a T4, but of total T3, free T3, reverse T3. Look at the big picture, and whether you see a functional or an allopathic physician, we shouldn't be rushing in with thyroid hormone too soon. In functional medicine, they say, oh, look, we need to give T3 because these doctors aren't seeing that we have a reduced conversion of T4 to T3. Reduced conversion of T4 to T3 doesn't mean we should give T3. it means there's something going on that's causing the reduced conversion of T4 to T3, and that's what we should address. Hope this helps. If you have any questions, put them below wherever you watch the video, or you can shoot me a message at my office email, office@rejuvegencenter.com. All right, hope that helps.